Okay, welcome back to the final session of the second day of the ICAMS conference. So now we are having the Young Investigator poster session where 10 young investigators will present their data, approximately 2 to 3 minutes per person. And this session will be moderated by Dr. Samaya Yunus. Welcome, Samaya.
Thank you, Chen, for the introduction. So as Chen just mentioned, we are going to have 10 interesting presentations, and each speaker has 3 minutes available for the presentation, which will be followed by immediately after, followed by 2 minutes of Q&A. So don't hold back with the questions for the speakers. So the first speaker is Dr. Anja Petersen. She is a PhD student at the Danish Headache Center, and she is going to talk about the burden of cluster headache. Unfortunately, she was not able to be here today, so her presentation is pre-recorded, so there will be no QA after this session. This presentation.
Hello, my name is Anja, and I'm a medical doctor from the Danish Headache Center. Cluster headache is a less prevalent primary headache compared to migraine, but it's overrepresented in regard to the use of healthcare and social services. More insight into the socioeconomic impact is required to increase funding opportunities and to facilitate understanding of the patient struggles besides the extreme pain attacks. Therefore, we asked 400 patients in a questionnaire followed by a semi-structured interview. We additionally asked 200 controls who were allowed to have a maximum of 1 headache day per month. We found that a chronic patient on average was 3 times more expensive than an episodic patient. We identified a substantial loss of productivity due to absence from work, resulting in a high annual indirect cost of almost 12,000 euros per patient in the chronic group, compared to only 3,500 euros per patient in the episodic population. The direct cost was almost equally high. Overall, 94% of patients reported restrictions in personal and/or professional life during the attack periods. Even in remission, the episodic patients rated themselves as limited in everyday life by cluster headache. Self-rated health is an important predictor of and strongly associated with increased mortality. In patients with cluster headache, we found that the self-rated health is severely affected. For the chronic patients, the odds of rating health as good were 10 times lower compared to controls and 3 times lower compared to episodic patients in remission. No significant difference was found in between episodic patients in bout and chronic patients, but the trend was that the chronic patient rated health worse compared to the episodic patients. As we see on the lower left corner of the poster, the chronic patients are substantially more impacted in personal and professional life. Here, I would like to emphasize that above 40% of the chronic patients were without work due to cluster headache, and 40% rated themselves as dependent on family and friends. And this was in a population where the mean age was around 45 years. In conclusion, patients with chronic cluster headache are vastly more burdened compared to the episodic. Patients with the episodic form were still markedly affected during the remission. And this study highlights the need for more effective therapy to lighten the burden for the patient and for the society. Thank you for listening and for tuning into my poster.
So thank you to Anja for her presentation. And as I said, there will be no QA for this, unfortunately. So we move on to the next presenter, who is Basit A, who is a medical student and researcher at the Danish Headache Center. And we'll talk about cluster headache and YouTube, an interesting topic. We're looking forward to it.
So, cluster headache, the worst possible pain on YouTube. So, the background for it. Well, in clinical practice, a lot of patients with cluster headache ask questions or misinformation which they have seen or heard on the internet regarding cluster headache. And this might interfere with best clinical practices in a both positive or negative manner. So some patients will be more knowledgeable, have more information about the disease, while others might have obtained inaccurate information or, worst case scenario, contradict best possibilities for disease management of their cluster headache. So Since YouTube is the second most well-visited website, we found it challenging to assess the quality and reliability on cluster headache videos that are freely available on YouTube. So the method for this study was that we used the web browser, Mozilla Firefox, in a private mode. We deleted all tracking cookies, and we used the search term cluster headache on YouTube, which gave us a hit of 644 videos. We only included videos with at least 10,000 views regarding cluster headache. In total, 134 videos. They were all categorized into 3 groups and assessed with a global quality scale and discern, which is, as you can see, a 5-point scale, the global quality scale, which assessed the quality of the videos, the ease of use of the video, and the flow of it. And discern is a reliability assessment of the videos, judging the reliability. So, as you can see here, regarding the one group which are videos produced by healthcare professional, 42% were of high quality. Personal experience with a patient showing them cluster headache, or something like that, there were 4% of high quality, and other was of 24%. Regarding the reliability, interestingly, only 1% from health professionals were of high quality personal experience. Well, yeah, as you can see. And regarding the other, it was 1%. So our results underline the need for videos of high quality and reliability that presents validated information on cluster headache. Yes. Also.
Thank you, Basit, for your presentation. So we have time for a question from the audience.
Thank you for the presentation. My question is, you say most of the videos are of low quality on YouTube, but the truth is, even if you create higher quality videos, you cannot control YouTube and you cannot control which videos the patient will actually access. So what is your proposal on how these better quality videos that should be created will be communicated more efficiently to the patients?
Yes, if I understand correctly, just to be sure, to make sure how we get true, reliable videos.
Yeah, I'm just saying that even if you create them and put them out in YouTube, it doesn't mean it will be the ones chosen by the patients or the people who are interested in that.
So we have, for example, if you look at TED Talk or other popular organizations, even musicians or celebrities for that matter, they have a wide range of social sharing on YouTube, and they are centralized. So if we can do the same regarding cluster headache, where we have some, like patient organization, recognized patient organization, or the IHS, for example, with leading experts in the field, and make sure they produce videos in a way that patients, normal people, non-healthcare professionals can understand, and make a wide social ranging, array. Then we can hopefully face yeah.
Thank you.
There's time for one more question. Yeah.
Do you have more time?
Mm-hmm.
Okay, one last question. What is the limitation here? Because we saw that you exclude videos with less than 10,000 views.
No, it's at least 10,000 views were included, and that's where we didn't include videos with less than 10,000 views. And the reason for that rational cutoff, we will say, is because people don't search for more than the first 3 pages generated. And this is supported by Eisenberg, who made a study regarding health information on social media, what kind of information people are looking for and appraise. So she showed in her study from 2002 that 10,000 views is the rational limitation, we say, including criteria for such kind of videos.
So if a neurologist just put a video yesterday and this was concerning the cluster headache, you excluded that?
Yeah, we excluded if it's below 10,000.
Time's up. So next presenter is Dr. Cédric Gollion, who is PhD from the University of Toulouse and currently a postdoc at the Danish Headache Center. And he's going to talk about migraine and stroke.
Migraine and large artery atherosclerosis in young adults with ischemic stroke. migraine with aura is associated with a twofold increased risk of ischemic stroke, especially in young women who are less prone to develop atherosclerosis. Then, we aimed at evaluating the association between migraine and large artery atherosclerosis after adjustment for traditional vascular risk factors. We included patients aged 18 to 54 treated for a first ever acute ischemic stroke between 2017 and 2019. Causes of stroke were classified according to the Ascot system. Ascot system allows to identify several causes of stroke, meaning that all patients were evaluated for atherosclerosis, and Ascot system also identify and recognize non-stenotic atherosclerosis. We included 415 patients, 76 had migraine with aura and 68 migraine without aura. Migraine patients were more often women, younger, with lower BMI and less hypertension. Migraine was negatively associated with atherosclerosis of any grade. Then we lump all grades of atherosclerosis from A1 to A3 versus A0, and we perform a logistic regression analysis. The association was adjusted for age, sex, smoking, hypertension, diabetes, hyperlipidemia, and overweight. And we confirmed the negative association between migraine and atherosclerosis after adjustment for vascular risk factors. Then we can say that this association is not only due to the overrepresentation of cardiac sources of stroke, such as patent foramen ovale in migraine patients, but we can speculate that the negative association could be due to a genetic polymorphism, such as the polymorphism of the gene PHACTR1, which has been shown to be associated to coronary artery atherosclerosis and migraine, but in an opposite direction. In conclusion, migraine was negatively associated with large arterial atherosclerosis after adjustment for vascular risk factors. Thank you.
Right, thank you so much for letting me present here today, and thank you for my team for being able to do this study. So a little background for my study. Now we all know that erenumab, what it is, but just to clarify that erenumab is a monoclonal antibody that's targeting the CGRP receptor, and it's used in the preventive treatment of migraine, episodic and chronic migraine. Here in Denmark, it's only chronic migraine so far, but in other countries it's used for both. Now, erenumab has been proven to be effective in phase 3 trials in both chronic and episodic migraine. And then when it was released here in Denmark in mid-2019, we were interested in seeing how the effect and tolerability of erenumab presented itself once we started treated in a real-world scenario. And so our methods was that we approached the first 300 patients who were started on erenumab and who willingly accepted us to be able to follow them, these patients, in their treatment in the clinic. And they were first diagnosed by a clinical doctor to verify that they had migraine, chronic migraine, and then we gave to them a headache diary in which they filled out their self-reported headaches and migraine days for 4 weeks prior to initiation of a treatment. And then we followed them for a total of 52 weeks, or a full year. And these patients were treated with 140 milligrams at the first visit. And then due to clinical guidelines or the clinical treatment, in the clinic they set up that all patients should be reduced to 70 milligrams after the first 3 months of treatment. So after 12 weeks of treatment, all patients were reduced to 70 milligrams, and then if they didn't have effect on the 70 milligrams, then they were increased again to 140 milligrams, and the ones who still had effect on 70 milligrams were kept on 70 milligrams. So what was the result of this study? So the efficacy results. So after 12 weeks of treatment, we see that around 70% of our patients have at least a 30% reduction in monthly migraine days. And this is a very positive finding. More than 2/3 of the patients in this study have effects of erenumab. And then on the long-term efficacy of erenumab in this cohort, we found that there was quite a lot of patients who didn't have a sustained reduction. So only about 34% we see here has a sustained reduction through the entire year of treatment. But this is also, even though it seems like this is a big difference, is also a good thing to see that that actually this many patients have a sustained effect, because these patients that we see in the headache clinic, the median number of prior migraine preventive treatments for this group was 7. So they have been through a lot of different prior treatments before this, which didn't have effect on these patients. So it's a good finding, and it proves that the erenumab is effective also in the most refractory patients. Now, in case of safety result, we had a lot of adverse events. Now, of course, we followed these patients for a year, so compared to some of the other studies where they only followed the patients for 3 months, you would also expect, if you give the patients treatment for a longer time, that there will be an increased risk of adverse events during the treatment period. But we found that 73% of these patients had any type of adverse event. Now, the topmost adverse event was constipation. We know this from prior studies, but we had quite a significant higher percentage of patients presenting with this of around 40%. Now, this might come down to how you ask the patients of their adverse event. And then, in regards to adverse event leading to discontinuation, we also had quite a high percentage of patients who stopped treatment with erenumab, around 14%. This is high compared to other studies. But a side note to this is that during the treatment, during the study, another antibody was released on the Danish market, and then the patient they had an opportunity to switch over to this other antibody if they had adverse events. So this is why it's quite a significant high number in this study. All right, and that's it for me. Thank you.
Thank you for your presentation. We have time for one brief question, and then we move on.
I have a question because there's often some confusion about response, consistency of response, and sustained response.
Mm-hmm.
So in the trials, of course, they defined response after 3 months, and there was even some difference because some of the trials used 12 months as the estimation of response, others they looked at the mean for 3 months. So you were talking about response and you were talking about sustained response, but wouldn't it be more practical to look at consistency of the response? So for each month that patients are treated, how many of these patients or which patients receive this 30% response during that month?
Yeah, so
did you look at those data as well?
We actually didn't look at each single month. For the 3 months period, we looked at the last month, which is according to the general guidelines for clinical trials for a 3-month period. And then for the 52 weeks, we look at a mean of every 3-month period. So that we took a mean of...
So your 30% reduction is a mean of 3 months per patient?
And sorry, yeah, for this outcome, for the sustained response, we took the mean for 3 months for the entire period. That's true. Yeah.
The mean for 3 months, but
Yeah, so each time period, so we had 12 months and then 24 months and then 36 months, weeks, sorry, and then 52 weeks. We took the average of the last 3 months prior to that and make sure that they had at least a 30% reduction throughout the entire period. If that makes sense.
Yeah, I'm not sure whether I still understand, but okay, we can discuss later. I think it's extremely important to that we have the same definition of response, whether we're talking about sustained or consistency of response, and also looking that we're not changing. Sometimes in the trials you see that at 1 month 50% of the patients were responders, but the next month the group is totally different. There are different groups with 50% reduction of, so it's not a sustained response.
Yeah.
So there's a mix up in presenting these data often in congresses, I think.
Mm-hmm.
Yeah, thanks.
Thank you for your presentation.
Yeah.
The next presenter is Dr. Haidar Al-Khazali, who is a PhD student at the Headache Center, and he will talk about neck pain in migraine.
Thank you so much. Well, hello everybody. Yes, I think we just have to move forward. I would like to present my latest work concerning the prevalence of neck pain in the migraine population. And yes, first of all, we know that neck pain is a very prevalent complaint in patients with migraine, and it also seems like that there is a kind of a correlation between the headache frequency and neck pain. So we also have some issues with the current literature because there's a lot of varying reports through regarding the prevalence of neck pain. So therefore we decided to establish or estimate the prevalence of neck pain in these patients. So therefore we conducted a systematic review concerning the prevalence of neck pain in the migraine population and compare these data with non-headache controls. And by this meta-analysis, we actually demonstrated that the pooled prevalence or relative frequency of neck pain is of 77% in the migraine population compared with 23% in the non-headache controls. Furthermore, we have this hypothesis that there was a correlation between neck pain prevalence and the frequency, and this is also something we have confirmed now by the meta-analysis because we calculated a relative frequency which was higher in chronic migraine patients compared with the episodic ones. Finally, and the most interesting part is that we also found that neck pain was about 12 times more prevalent in patients with migraine compared with non-headache controls, and about double as frequent in chronic migraine patients compared with the episodic ones. Well, this is a systematic review, so we have to replicate the method, and that's why we use 2 databases, PubMed and Embase, and prior to this search process we also made a protocol which was registered to Prospero, and once it was approved we initiated the final or the resting part. At the results section I have taken a figure with us here which demonstrates the blue line, which is the migraine patient compared with the non-headache controls, and on the other section the orange demonstrates the relative frequency of episodic migraine patients compared with the red ones who are the chronic patients. And through this data we also might admit that our data has to be interpreted with some caution due to the high heterogeneity among the studies. And this has to be addressed in future directions, that we have a clear lack of neck pain definition in the migraine literature and also in other literature concerning the neck pain at all. Furthermore, we have also a lot of patients who are female participants and very few male participants in these studies. We also have a clear lack of reporting in these included studies that if the patient also have other headache types such as tension type headache, post-traumatic headache, and so on. And we also have a lack of information concerning when does the neck pain occur regarding to the headache onset? So is it before, is it during, or after the migraine attack? Yes, that was it.
Thank you for your presentation. We have time for one question.
Thank you, Haidar. I have a quick question. The studies you included, the headache incident, the neck pain incidents that you report, was it during the headache, between as a general complaint, or both in these studies?
Well, we included all studies reporting neck pain prevalence. So we actually only included 6 studies that reported when the neck pain was regarding the onset of the migraine attack. So we included actually everyone who said or complained from neck pain.
Thanks.
Thank you for this excellent presentation. Neck pain is a bit general. If there are different kind of neck pain, I mean, some patients mostly have pain in the occipital region or in the shoulder. Maybe the pain is not the same with cervical disease or migraine disease. Do we have some details?
Actually, no. The neck pain literature right now is just maybe like the headache literature 40 or 50 years ago, where headache was just headache. It wasn't classified as tension type or migraine. And the same is with the neck pain right now. So we have very few data concerning the neck pain information at all, and we don't have any kind of classification. Furthermore, we have a lot of structures in the neck, so it could be occipital, it can be the trapezius part, or the cavities minor or major. So I think we have different pain structures there, and also ligaments that could initiate the pain, and it might also be different from one structure to another.
Thank you, Haidar, for your presentation. So next presenter is Dr. Lili Kokoti, who is a PhD student at the Danish Headache Center, and she will talk about glibenclamide and paragraph 38.
Hi, I will tell you about the study we conducted at the Human Migraine Research Unit, where we tried to see the effect of, I have to change it. Yes. The effect of KTP channel blocker glibenclamide on PACAP 38 induced headache and hemodynamic. So a quick background is that, as you see, we know that when we give PACAP 38 intervention fusion in migraine patients, they get migraine attack, and in headache, in patients with just normal headaches, they get plain headache that in both cases is accompanied by a pronounced extracerebral vasodilation. Preclinical studies show that how this vasodilation happens is a possibility that through activation of its receptors in the vascular smooth muscle cells, PACAP activates intracellular cascades that in the end, among other molecules, there's an activation of KTP channels. The KTP channels open, there's potassium efflux and vasorelaxation. So now we try to use glibenclamide, that is a non-specific KTP channel blocker, to try and block the effects of PACAP 38 in healthy participants. So we recruited 20 healthy participants that would come on the headache clinic on 2 different study days. On both days, they would receive at baseline for 20 minutes PACAP 38 infusion, and then on one study day they would receive glibenclamide at the end of the infusion and placebo on the other day. And of course it was double blind, and no one would know which day they would receive what. So for the next 4.5 hours they would remain in the clinic, and we would assess their headache and any accompanying symptoms, and also we used ultrasonography to access the diameter of the superficial temporal artery and the velocity of the middle cerebral artery. After that, they would go home with a 12-hour headache diary that would correspond to 12 hours post-PACAP 38 infusion. So now we see in the results on the top right that PACAP 38 on both study days induced significant headache, and it also dilated significantly the superficial temporal artery. However, there was no difference between the incidence of headache or the area under the curve for headache between the 2 study arms. And the same goes for the diameter of the superficial temporal artery. So to conclude, glibenclamide was not able to block the effects of PACOP38 in healthy participants, and we need more specific KTP channel blockers because glibenclamide is far more sensitive for the KTP channels in the pancreas, but not in the vascular smooth muscle cells. And up to now, we don't have that in our hands, selected for the vascular smooth muscle cells KTP channel blockers. Thank you.
Hi Lili, I have a question for you because I was wondering why you chose to give the glibenclamide after that you gave the infusion, because if you give the glibenclamide orally, you also have to take into account the absorption time and not everything like that.
Yes, thank you very much. So the absorption time is one thing, because even if you would give it as pre-treatment, we would still have this problem, and of course we expect the results to be 30 minutes at least post the dosing. But the overall reasoning behind that is that in migraine patients, where in a study conducted by Nita, a former PhD student, when they would give sumatriptan, another treatment for migraine, as post-treatment, it actually worked. However, in other studies, I think it's conducted by Dr. Galizada, as pre-treatment, it didn't actually block the vasodilation. So there is this rationale of the activated receptors, but of course it's not proven, but that was the rationale.
Thank you for your question.
Hello, I am Rune Christensen from the Danish Headache Center, and I would like to present to you our study on arterial responses to glycagon-like peptide 1 called GLP-1 in humans. So GLP-1 is a neuropeptide that regulates glucose, but which importantly also has effect in the periphery, where it dilates vessels, and in fact can induce headache, at least in clinical trials in diabetes. As you know, several neuropeptides that dilate cephalic vessels are actually able to provoke a headache in healthy participants and migraine in migraine patients. Because of this, we chose to examine whether GLP-1 could perhaps dilate cephalic arteries and induce headache in healthy participants. To do this, we included 20 healthy controls of participants in a randomized, double-blinded, placebo-controlled, two-way crossover design to receive either GLP-1 or placebo for 20 minutes on 2 separate days. We also clamped glucose to prevent hypoglycemic effects of GLP-1. So we measured during and after the infusion the diameter of the superficial temporal artery and the radial artery using dermoscan technique. Furthermore, we measured mean blood flow velocity within the middle cerebral artery using transcranial Doppler. Finally, we recorded headache characteristics and associated symptoms of headache during and after the infusion. We found that GLP-1 did not dilate the superficial temporal artery or the radial artery compared to placebo, and did not alter mean blood flow velocity within the middle cerebral artery. We also found that GLP-1 did not induce more headache than placebo. This suggests that GLP-1 is an unlikely candidate for an experimental model of headache, and also an unlikely future model for migraine, especially since all migraine-inducing compounds so far have been vasodilators. However, our study has an important clinical implication, in that GLP-1 has recently emerged as a putative treatment for idiopathic intracranial hypertension. Our study suggests that GLP-1 can safely be used to reduce intracranial pressure in IIH without aggravating the headache associated or attributed to IIH. Thank you all for listening.
Okay, thank you, Dr. Christensen, for this. Christensen, Danish Headache Center. This is an interesting, I think, idea that to always do these studies, and that's what we do in the human migraine models. We do in healthy controls and then move on to migraine patients. And we just heard Dr. Do speak about this fact that all migraine inducers are vasodilators. But doesn't it become self-fulfilling prophecy if you use it as a marker for moving to migraine patients or not? What are your thoughts on this?
It does more or less, especially because we do not measure, of course, all the arteries using the techniques we have. It would be better to use, for example, MRI angiography to detect this in a more sensitive manner. However, so far we have actually had a couple of negative compounds that did not dilate the vessels, such as adrenaline and endothelin and prostaglandin F2 alpha. So at least so far it seems to stick, even though there are also vasodilators which do not induce migraine. So yes.
Thank you. We have time for one more question.
Yes, thank you, Rune H from the Danish. Oh, sorry. I'll try again. Okay. I'll try again. Rune H from the Danish Headache Center. Thank you for a very nice presentation. I was wondering, how did you determine the dose, the applied dose of the drug?
So this is actually the highest dose ever administered to humans. We did what previous studies did, and then we did a dose-finding study to determine what could be tolerated and what would perhaps have the greatest arterial effects. And then we, since there were no adverse events with the highest dose we had in the pilot study, we went with that. So this is how we determined it. We did not go higher than this because we were afraid of hypoglycemic effects by further increasing the dose. Yes.
Thank you. Thank you, Rune, for your presentation. So next presenter is Dr. Stine Maarbjerg, who is a postdoc at the Danish Headache Center, and she will talk about arenomab in trigeminal neuralgia.
Hello, everybody. Trigeminal neuralgia is one of the most painful conditions known to mankind. There is a massive need for better tolerated treatments. CGRP antibodies has changed the treatment and the landscape for migraine treatment. What if we could do the same for trigeminal neuralgia treatment? That is what we set out to do in this randomized, controlled, double-blinded trial that I'm going to tell you about. My name is Stine Maarbjerg. I'm a postdoc at the Danish Headache Center, and this study was funded by Novartis. So for the methodology, the trial design consisted of a 4-week baseline period. Then we had a double-blinded, one-to-one randomization with 40 patients receiving arenomab 140 milligrams and 40 patients receiving saline. That was followed by a 4-week treatment period where we followed the patients with daily diaries on pain intensity and number of paroxysms. So for the study population, we were able to include 23 men and 57 women. The mean age of onset was 56 years. And for the outcomes, we defined that the primary outcome was how many responders had a 30% or more decrease in the pain intensity when comparing the baseline period and the treatment period. The most important secondary outcome was how many patients had a 30% decrease in the number of daily paroxysms, again comparing baseline and treatment periods. So for the results, for the primary outcome, there was a decrease by at least 30% in pain intensity. We found that 35% of patients were responders in the active group receiving arenomab. And that was compared to the placebo group where 45% were responders. Now looking at patients with respect to reduction in number of paroxysms, it was a similar picture. There was 33% in the active group that had a decrease in paroxysms versus 53% in the active group. So we conclude that arenomab did not reduce pain intensity or the number of paroxysms in patients with primary trigeminal neuralgia.
Thank you for the presentation.
Thank you very much, Stine. A very nice study. I'm Faisal Lee from Danish Headaches, and actually you are a neighbor office. And I just have a question. I think the placebo response is quite high. And if it is so high, maybe we should use this as an add-on therapy in the clinic. What do you think? What is the explanation for so high placebo response?
Well, possibly because we're looking at the 30% responder rate, and in many of the migraine trials, you were looking at the 50% responder rate. When we look at our 50% responder rate, it was 18% that was the placebo response. So that is a little bit lower. Of course, I think it's a horrible idea to spend money on the placebo response and just treat according to that. But I know you do as well.
Thank you.
Thank you, Stine. Thank you for your elegant presentation. My question is also regarding the placebo response. What I found interesting, I mean, it's quite high, right? But we also see quite high placebo response in migraine, including the trials using the monoclonal antibodies. One of the explanations in migraine trials, we had that those patients with a high placebo response, they were pretty much preventive treatment naive patients. So those who tried many different medications, they had a quite low placebo response. Did you look at these two groups in terms of the medications they tried before, previous failures in terms of efficacy and adverse events?
Yeah, yes we did. Patients in both groups, the majority of them were treatment naive, meaning they had tried 1 to 2 drugs, typically prophylactically against trigeminal neuralgia. So they were patients that were easy to treat in the clinic.
What about the previous studies in trigeminal neuralgia? What about placebo response in these trials?
There was one good trial, RCT, 5 years ago, and it was approximately the same.
The same?
Yeah.
Thank you.
Thank you. Thank you, Stine, for your presentation. Last but not least, next presenter, final presenter, Dr. Thien P, who will talk about, you may know him by now, PhD student at the Danish Headache Center, and more to that. He is going to talk about Rune H and hypersensitivity to CGRP and cilostazol.
Hi again, General MD Research Fellow at the Danish Headache Center. So today I will show you a figure that a lot of you have seen already a few times by now. So molecular signaling pathways. We know when CGRP binds to its receptor, there's an increase in intercellular cyclic AMP that leads to vasodilation and then leads to a migraine attack. We have talked about this many times today. What we haven't mentioned is that this is largely based on indirect evidence. A trial in humans have never been conducted that directly tests this hypothesis that cyclic AMP acts downstream of CGRP in terms of migraine attack cascade. And more recently, there's preclinical evidence that suggests that migraine attacks are dependent on a CGRP feedback loop from E.S. Olsen's group. So to investigate whether this is the case, we conducted a parallel trial where patients either get a monoclonal antibody targeting the CGRP receptor, Rune H, or placebo. So patients either got the treatment as receptor blockade or they got placebo. And then they got CGRP on one day and cilostazol on another day. And cilostazol increases intercellular cyclic AMP downstream of the CGRP receptor, so it blocks it, so it bypasses it. So 2 arms, 1 placebo, 1 active, both arms get active triggers. So what did it show? If you look at the CGRP first, if you give placebo treatment and then CGRP, approximately 53% of patients get a migraine attack, which is pretty much consistent with previous CGRP provocation trials. Now, let's look at what happens if we introduce a CGRP receptor blockade. Here, the induction rate drops.
It doesn't drop completely, but it does drop. If we look at the physiological response in terms of vasodilation, now the red line are those who got placebo and CGRP, and here we see a large sustained vasodilation, again consistent with previous reports. But look at those who got the active treatment. There's still a little bit of vasodilation, and Dr. Al-Khazali was kind enough to share some of his historical data where he gave placebo saline infusion. So this is not just a, so to say, an effect of lying down in a bed. This is an active effect, which may also explain why there's still an increased induction rate, even though they're supposed to be completely blocked. And this may suggest other receptors involved. Now, if you look at cilostazol, the proposed downstream mechanism, if we give cilostazol to patients who are pretreated with placebo, we get an induction rate of approximately 80%. Again, consistent with previous reports, no surprises there. Now, the big question is then, what happens if we block the CGRP receptor and then give cilostazol? Well, pretty much unchanged. So based on these data, migraine attacks, or at least cyclic AMP generated migraine attacks, are not dependent on a CGRP receptor feedback. So, as it turns out, the vasodilation is also unchanged between the two groups. So, can CGRP receptor blockade prevent CGRP-induced migraine? Yes, at least partially. Can CGRP receptor blockade prevent cilostazol-induced migraine? No. So the conclusions are as following. So these proposed downstream mechanisms are truly downstream of the CGRP receptor, which suggests that migraine attack generation, at least through cyclic AMP, is not dependent on a CGRP positive feedback loop. Thank you.
So we have time for one question.
Thank you, Thien. Very interesting study. I just have a question. Could there be two different pathways? One is the CGRP pathway, one is cilostazol pathway, and not one pathway with different, not a single pathway where you have upstream and downstream.
Okay, so can I try to rephrase the question? So you're asking if cilostazol is completely separate for CGRP-induced migraine?
Yes.
Well, both yes and no. We know from preclinical data that cyclic AMP is the second messenger of the CGRP receptor. The thing is, cyclic AMP is also a second messenger for other receptors, PACA, amylin, adrenaline, and so on. So both yes and no. Cilostazol is downstream of the CGRP receptor. We know cyclic AMP is downstream of the CGRP receptor, but we also know that cyclic AMP is the second messenger of many other receptors. But based on these data, at least we know that cilostazol does not require the CGRP receptor to induce migraine attacks.
Thank you. Just one short additional question. You saw a little difference between these bits, but it was not statistically significant as I could see. It was 82 and 76. What would happen if you used a lower dose of cilostazol? Could the difference between attack induction be more pronounced?
So you're absolutely correct. There was no statistically significant difference, and they're both within the confidence intervals of previous reports also. So even if we went to a lower dose, I do not think the difference between the active and the placebo group will be different, because this is more due to chance than anything.
Thank you, Thien, for your presentation.